All right, so that was hypercalcemia. Let's do hypocalcemia. And again, it's going to follow physiologically from what we just did. So if we talked about the regulators of PTH too much and vitamin D too much causing hypercalcemia, right? So if we have failure, there's no PTH or no vitamin D, right? We're not going to have hypercalcemia, we're going to have hypocalcemia. So the question becomes, how do you fail? How do you get these things to fail? So let's do PTH failure first, right? So you can fail to develop the darn thing, or we can remove it. And so this is the classic vignette. Patient went in for surgery. After surgery in the recovery room, they're developing carpopedal spasm, Schwastek sign. They describe it to you, and they want to know what the surgery was. And then your choices don't include parathyroid. It's like, what the heck? It's thyroid. It's the thyroidectomy. Why do I waste your time saying parathyroids are located behind the thyroid? Because of this. Right? You take out the thyroid, you incidentally remove the parathyroids. And this is a big ticket item clinically too. This is from Dr. Coyne's lecture. I just thought it was great. You know, talking about localizing the parathyroid. The best localization approach to parathyroid surgery is to localize a good surgeon. All right. So surgical removal, right? And again, how they're going to describe it, this is how they're going to describe it. You know, this carpopedal spasm, nurse inflates the blood pressure cuff in the recovery room, the hand goes into spasm, or the Schwastek sign, facial twitching. And they do one or the other. There's a gratuitous slide on those symptoms. And again, the idea of lowering the threshold potential for depolarization. So cramping, twitching, hyperreflexia. And again, you'll see also in vignettes, tingling, numbness, just be open-ended to neurologic signs and symptoms associated with electrolyte disturbances. All right, so we can remove the parathyroid incidentally, or we can have this failure development. And again, that idea of applied embryology, I showed this previous, right? So you didn't develop it because you had failure of the pharyngeal pouches, which included the thymus as well. But part of that also include the conotruncal defects of the pharyngeal system. So there's Degeorge syndrome. And to my review, students just seem to be infinitely familiar with it. I just want to remind you again, if they give you an actual calcium level that's low, that's easy. Sometimes they'll just describe the symptoms, thymic shadow or equivalent. They're going to talk about opportunistic infections in an infant or a young child. And finally, the presence of a murmur. And ultimately, you know, what is the diagnosis to George? What's the genetic abnormality, the 2211 microdeletion? And the way they do this, get used to this little guy up here in the corner, this mix and match. Because when you have these syndromes, plug in your favorite syndromes, they'll give you something. They're going to give you a murmur and tell you something wrong with pharyngeal pouches 3 and 4. What else can be seen? Immunodeficiency, hypocalcemia. So it's a real just mix and match gestalt, and you just have to be clicking on all cylinders on these kind of questions. Lastly, and this will explain why we get into the next lecture when we do. So we talked about PTH failure. We just talked about failure to develop. There's this other concept of hypocalcemia. And again, these secondary disorders, functional disorders, calcium insufficiency, if you will. And one thing is the whole issue of fat-soluble vitamin malabsorption. And I'm choosing that as the next lecture because it just permeates everything else and just keeps coming up. I wanted to get that on the table straight away. So you don't absorb vitamin D, you're going to wind up, functionally with hypocalcemia. And we've already alluded repeatedly to the renal osteodystrophy story. I'm telling you, it just doesn't want to go away. Now we understand about secondary hyperparathyroidism. But the point is, without calcitriol and with hyperphosphatemia, we wind up with this functional hypocalcemia. And I think this is where we're going to end. So in the fat-soluble vitamin story, the malabsorption, again, that's going to be our next lecture. You have to understand the steps in fat absorption, and it brings us ultimately to the bony manifestations of that vitamin D failure. And we'll cover those during MSK, rickets, osteomalacia, these bone pathology. It's all very integrated, and it's really part of this hypocalcemia curriculum that we'll get further into that is going to reappear when we do MSK. This was the last question we did in January, not to bring up bad memories, but this was the patient with diarrhea, fragility fracture. That was the fragility fracture in a patient ultimately diagnosed with celiac disease. What happened there? They were malabsorbing vitamin D, hypocalcemia. They wound up with a insufficiency fracture. So again, it's the idea of calcium crossing organ systems for sure. So with that, that's where we are. So you'll appreciate that the next lecture I am doing fat absorption, not because it's such a beautiful, captivating topic, but because it follows from this one and it crosses organ systems. And obviously, it's going to be a huge prequel to when we get to metabolic bone disease. Here's my summary slide on this. And that is it. So we can take a break here.